Hello and welcome to the AOT Pod, an FRCS themed podcast tackling key themes, challenging topics and insightful intellect within otolaryngology, hosted by myself, Livy Kenyon, and my co-host Carla Kumaresan, with support from the ENT UK Foundation and Association of Otolaryngologists in Training. Your guide to passing the FRCS starts here as we take you around the country to some of the best and brightest minds our specialty has to offer. So without further ado, let's begin.
Hello.
Hello.
So I am joined today by Mr Philippe Bowles, and we are recording at University Hospitals Sussex NHS Trust. Mr Bowles did his higher surgical training in the Kent-Surrey Sussex Deanery and is now a consultant here in Brighton. He has special interests in laryngology and rhinology, including performing endoscopic transnasal surgery in the management of complex eye conditions alongside surgeons from the Sussex Eye Hospital. He is a widely published researcher and has presented his work at national and international academic meetings and conferences. Mr Bowles is a passionate educator and advocate for trainees. He is the clinical lead for ENT education and is a faculty member of the Master's Programme in Surgical Sciences at the Brighton and Sussex Medical School, as well as at the International Brighton Endoscopic Orbital and Lacrimal Surgical Dissection course. Mr Bowles also runs a weekly Friday morning teaching session for all resident doctors within the ENT department at Brighton. And I remember all too well being grilled when I was an SHO there. So the tables have now turned, and it is Mr Bowles' time to sit in the hot seat for this episode of the AOT pod. We will be discussing granulomatous diseases in ENT. And actually, you're on call at the moment, and you've just had a phone call about a patient with a suspected granulomatous condition. So this is all very relevant. So welcome to the AOT pod, Mr Bowles. Thank you so much for being here today.
Thank you. Thanks for having me. Thanks for inviting me.
That's great to have you here. As usual, we will start with some questions about your personal experience of sitting the FRCS, which, of course, for many trainees is quite a nerve-wracking prospect. So when did you take the exam and what else was going on in your life at the time?
I sat the exam in 2019. I did part 1 in January and part 2 in April. And I think the exam comes along and we're senior registrars, and it's a really busy time in life. Domestic life might finally be starting to take off, maybe buying houses, starting families, getting married. So there are more demands on your time. And at the same time, your workload goes up, because as well as doing a busy surgical training job, trying to line up a job or a fellowship afterwards, you've got to pass this exam, which is the last rate limiting step, and you're actually fulfilling your objective. So when I took the exam, we were renovating our house, which we'd just bought. We'd stripped it back to the brickwork. I was commuting to Great Ormond Street from Brighton, which is a 4-hour return journey daily. And I was doing full-time masters around my job, and we had a 6-month-old baby at home. So it was really hectic. And I was having to do the exam. And I remember after it was all over, my ARCP, and being asked by the panel about it, about how my year had been, I sort of told them what I'd been up to and what I'd had on. And they all had this 1,000-yard stare on their faces. They were kind of remembering that stage of their lives, which they've blanked out since. And I realised that it's just part of surgical training, and it is tough and it is demanding, and you do have to be resilient, but it'll give you a lot of knowledge, all the knowledge you need to have a really successful career, and the resilience you need to be a good and productive consultant surgeon. So it works.
But in retrospect, was it really the opportune time to renovate your house?
Maybe that could have been done later.
You mentioned some of them already, but it sounds like there were a few challenges when you were studying for the exam. Yeah. How did you manage them?
Yeah, so I think, it's having insight that time management's the issue here. And there's a tendency to, blame oneself that they're not particularly good at it. But actually, that's probably not true. You actually are just trying to fit an awful lot into not much time. And you're trying to maintain a high level of performance in everything you do. So I think it's recognizing that and celebrating the things you do achieve in your day or week, rather than lamenting the things you set yourself that you didn't get around to. Because it's almost certainly not because you've been sitting around wasting time. Plan ahead as much as you can and be realistic. And you have to be a bit selfish with your time. So I remember revising the study at home for the exam while my wife was dealing with our newborn, and fighting the instinct to go and help, and actually staying with your books, because it's all about only doing it once. That's best for all concerned. So actually focusing on the exam and your studies and prioritizing everything to make sure you get through first time is the best way. But you do have to be a little focused, and it can feel selfish at the time. But honestly, ask them if they'd like you to do it once or twice. They'll generally say once.
People will say twice.
Yeah. And then knowing you're not the only one who's going through it, has gone through it before. I was lucky enough to have a couple of relatively junior consultants in our department who were supervising me, to speak to about what was going on, and they shared their experiences with it. And I realised that it is demanding and testing, but everyone's been through it and everyone does get through it. Yeah, absolutely. And everyone recognises what you're going through, and the support's there if you need it. Yeah, and it's worth it. So, I mean, for me, ENT is the best job in medicine and maybe the best job out there. So it's definitely worth it.
Oh, so good to hear. So you must have been pretty chuffed when you found out that you'd passed. How did you celebrate?
It was more actually finishing the exams when we really celebrated. But there's a bit of a tradition of, all the post-exam group going out for drinks in whichever city in the UK and Ireland the exam happens to have been held in. So I went out with my friends and also the other people I knew from the cohort, and we celebrated. I had quite a busy evening. That was great. And but in terms of when I got the exam, the result itself, it was just an overwhelming sense of relief. I still see the two of my sort of best friends who I prepared for the exam with. They're both consultants in London now. We meet up 2 or 3 times a year to catch up. So in a way, we're still celebrating.
Oh, very good. All right. Well, thank you very much for all those words of encouragement. I'm sure that'll be very helpful for those listeners who are preparing for the exam. Let's move on to our clinical scenario.
Sure.
A 42-year-old Caucasian man presents to a rhinology clinic with an 8-month history of nasal symptoms. He has bilateral obstruction and facial pain with intermittent crusting and epistaxis. He has a chronic cough and is feeling quite fatigued. What are your differential diagnoses for this patient, and how would you assess him?
Great. So, I mean, on the face of it, this is a really common presentation to the rhinology clinic. And the commonest cause of nasal obstruction in the context of facial pain is chronic sinusitis. And that can also give you some of the less specific systemic symptoms you mentioned. But the presence of epistaxis raises the index of suspicion for more concerning illness. Malignancy clearly has to be ruled out as priority. The surgical sieve is often a good default to apply, particularly when you're answering exam questions, as it shows a structured and ordered approach to your thinking, and it gives you a framework to put your answers into. Also reassures the examiner because it's an answer they're used to hearing. They're ready for the reply, and it shows a logical approach. So if you're, in terms of differentials, we've touched on CRS, we'll start with inflammatory. Also allergic rhinitis, you wouldn't necessarily get facial pain, but certainly the congestion and rhinorrhea. Other inflammatory conditions, less specific, sarcoidosis and certain recreational drug-induced destructive processes, which can cause chronic inflammation, such as cocaine-induced midline destructive lesions. And related to that as well, levamisole-induced necrosis syndrome. Infective conditions, so recurrent acute rhinosinusitis, shorter duration than chronic sinusitis with similar symptoms, fungal sinusitis, and the various taxonomy of different types of fungal sinusitis all fall into this parameter. And infected mucocele as well. Malignancy or neoplasms, say SNUCs, sinonasal undifferentiated carcinomas, are increasingly common, about 12 a year through this department. Squamous cell carcinomas, minor salivary gland neoplasms such as adenoid cystics, T-cell lymphomas and adenocarcinomas. Your vasculitic title, you're going to mention GPA and eosinophilic GPA. Autoimmune systems, things like lupus and relapsing polychondritis, and then even trauma and iatrogenic causes are relevant to this patient cohort. Trauma, particularly in the light of epistaxis, iatrogenic as well, which can be chronic or acute, particularly following sinus or septal surgery.
Yeah. Okay, so quite a broad differential really at this stage. How would you assess a patient like this?
Well, so in terms of assessment, you're going to need a focused history and examination. It's what we're trained to do. It's what the exam expects. And actually, when you get it into consultant job. You get 15 minutes really to extract the information, do an examination, arrive at diagnosis, and then 5 minutes to document. So you're going to want to be focused. Mostly around the history of the presenting complaints. The onset, the duration, and progression of symptoms are key. I like to apply the EPOS guidelines for chronic and acute rhinosinusitis. So for a diagnosis of CRS, you need 2 symptoms, one of which has to be major. So the major symptoms are obstruction and rhinorrhea, and the minor symptoms are hypotonia and facial pain. Any 2 of those, with one of them being obstruction or rhinorrhea, and you have a diagnosis, and that helps you expedite the appointment and move towards a diagnosis and treatment plan, or a way of thinking prior to examination. Other symptoms, crusting, epistaxis we've touched on, and failed response to previous treatment. It's really relevant because in the community, and again, the EPOS guidelines have a section for primary care providers, they will often have been advised to do saline rinsing prior to your appointment, likely a trial of a topical nasal spray, possibly a combination steroid and antihistamine spray, possibly drops, and maybe even oral steroids. And that's actually quite helpful because it gets you 1 or 2 appointments down the treatment pathway by the time they get to you. Bear in mind ear symptoms. The sinus nasal outcome test score that we use for diagnosing CRS has, I think it's 5 parameters relating to ear symptoms. You get hearing loss, otalgia, sensation of blocked ears. So you want to ask about ear symptoms. Throat symptoms, so with more systemic vasculitic conditions and autoimmune, you can get laryngeal involvement, which can affect voice change, stridor, shortness of breath. Quite a high proportion of them will have a degree of paced-nasal drip, which will give them a degree of dysphonia. Other symptoms, cough, hemoptysis, again thinking more about systemic conditions affecting with pulmonary involvement, shortness of breath, hematuria, lethargy, arthralgia, weight loss, and eye symptoms such as uveitis and scleritis.
A lot to cover.
A lot to cover. I think the things you're going to focus on the history of presenting complaint in your limited time in the exam. For the past medical history, I mean, obviously you want this to be as comprehensive as possible. I specifically ask about asthma due to the high concordance rate with CRS and certain other vasculitic conditions. I also ask about previous nasal surgery or sinus surgery, partly as a cause for their symptoms, but also if they've had 4 previous sinus surgeries before, obviously moving towards query recurrent CRS or undertreated CRS. Family histories are obviously relevant for all the reasons we've discussed above and the conditions and the differentials. Social history, so particularly recreational drug use, we talked about cocaine. Also, ketamine is quite popular in Brighton now. Patients tend to snort it, and that can give you localized vasculitis. Smoking history, particularly thinking about malignancy, but also more simply, inflammatory rhinitis as a reaction to the smoking irritation on the lining of the nasal mucosa and impairment of the mucociliary clearance pathways. Occupations relevant, famously nasopharyngeal carcinomas associated with dust exposure, particularly adenocarcinomas. So it remains relevant. And then you're going to move on to your examination.
In terms of examination findings, what are you looking for in a patient like this?
Mostly, the examination is going to focus on the nose. You're going to approach the patient, you're going to look externally at the external appearance, particularly the shape of the nose in certain conditions that affect the nasal septum, vasculitis, when you get breakdown of the nasal cartilage and the support system for the nose. Early signs be supratic depression and then eventually saddle nose deformity. Anterior rhinoscopy is always good to perform as part of it, although you're probably also going to proceed to flexible nose endoscopy and examination of the internal nose. If in your differentials you're still considering a vasculitis or autoimmune condition, it's worth examining the larynx, look for any granulation tissue, subglottic stenosis or supraglottic granulation. It's worth examining the ears, especially if they've described ear symptoms during the history and you're looking for an effusion primarily. And then if we haven't ruled out malignancy and with the bleeding, that's still in our differentials, then it's worth examining the neck to look for any palpable lymphadenopathy.
And might you get enlarged lymph nodes with an autoimmune condition as well?
Quite sarcoid classically, and lymphomas and malignancies, metastatic.
Okay, well, so this clinical scenario, let's say that the examination is normal, apart from on flexible nasal endoscopy, you see crusting, adhesions, and a large septal perforation. What investigations would you request?
So perforations come in shapes and sizes, and there's a huge difference between a small iatrogenic septal perforation with clean mucosalized edges from which the patient's asymptomatic, and the huge destructions of the septal cartilage you see with vasculitic conditions, and particularly the recreationally drug-induced vasculitis. So the investigational request would depend a little on what the perforation looked like, but assuming it was a large, fairly necrosed cartilage looking inflamed.
It looks really mangy.
You're going to do a full set of blood tests. You can do a full blood count, any anemia and eosinophilia, with the latter being obviously Churg-Strauss syndrome in mind. ESR and the CRP as markers of inflammation, use an e-slit for any potential renal involvement with GPA. So a C-anchor and a P-anchor, as well as a ACE, which would do for sarcoidosis. C-anchor is quite good for GPA, and P-anchor tends to be more specific for eosinophilic GPA. Think about urinalysis, look for hematuria. You get glomerulonephritis with GPA, ketamine cystitis with ketamine abuse, and you may wish to test the urine for cocaine with their agreement.
Having done those investigations, would you request any imaging for this patient?
I actually have a much lower threshold for requesting imaging as a consultant. I did as a reg. I think CT scan of the nose and paranasal sinuses particularly, they've already had the early intervention treatments in the community, and they're still symptomatic. So CT scan of the nose and paranasal sinuses is incredibly instructive in showing that mucosal inflammation. It also gives you a lot of information about the bony integrity of the nasal septum and paranasal sinuses. If you're worried about malignancy, especially if you have any unilateral symptoms, clinical findings, I have quite a low threshold for a contrast MRI scan. And if I'm worried about metastatic disease regionally to the neck, then I'll include the neck in the MRI scan of the skull base and sinus. And then again, if in your differentials you're still considering systemic conditions such as sarcoidosis, a chest X-ray is relevant, or probably a CT scan of the chest, which you could include with your CT scan of the sinuses.
Okay, great. Thank you. And how do you test for cocaine in your unit? Is it straightforward to do?
It is actually. We don't test for it routinely, and within the confines of a confidential clinical consultation, I'd hope that I'd be able to establish a degree of trust where the patient wouldn't feel they'd need to conceal that from me. But in the event that it was necessary to test, we're obviously going to need the patient's agreement. But we have it available to us via A&E with urine analysis. You can also do saliva swabs with it, but that's not something we have available here currently. With urine analysis, you can normally detect the metabolites of breakdown in cocaine for about 2 or 3 days, and then heavy users for up to 2 weeks.
So let's talk about anchor. In this scenario, the blood tests come back positive for PR3 C anchor. So what does this mean, and what is the sensitivity and specificity of this test?
Yeah, so anti-nucleotide cytoplasmic antibodies, C anchor, it has quite good sensitivity picking up GPA and up to 99% specificity for active GPA. So 91% sensitivity, 99% specificity, it's a good test for GPA. So if the patient's coming back with a PR3 C anchor, a positive C anchor, you've got to, reasonably confident of your diagnosis of GPA. P-anchor does have an up to 40% sensitivity for GPA, but it's also positive in lots of other autoimmune and vasculitic conditions. So that's fairly low specificity. But with our high C-anchor, then I think, we're thinking it's probably GPA.
Okay. So C-anchor is supposed to be positive in GPA. P-anchor, is that the one that goes with Churg-Strauss?
That's right. Yeah. Eosinophilic granulomatous. So it's
not called Churg-Strauss.
I think the antibodies in the P-anchor for eGPA to bind to MPA peroxidase.
So what do we mean when we say granulomatosis with polyangiitis or GPA?
So it's relatively poorly defined. It's a disease of unknown etiology. We thought it may be autoimmune, but it's a vasculitis that affects small and medium-sized vessels with multinucleated giant cells in one or more systems. So classically in GPA, nose or respiratory system, the kidneys or the lungs. Giant cells are fusions of macrophages and monocytes that's seen on histology. So a classic triad of symptoms for GPA, and a way of remembering it would be to think of upper respiratory tract, lower respiratory tract, and renal involvement.
And part of the workup for this sort of case, would you perform a biopsy, and what would be your considerations?
Yeah, again, it depends a bit on the appearances of septal perforation, what you're trying to achieve with your biopsy. I think if you're concerned about malignancy, there's definitely diagnostic value in that. The diagnostic yield for GPA from a biopsy is actually fairly low. And a lot of units, if diagnostic confirmation with tissue biopsy is required, will prefer a renal biopsy, with glomerulonephritis being fairly specific for GPA, especially in the context of a positive C anchor. That said, it's fairly easy to do, low morbidity for the patient. You can do it under local anaesthetic. You consider the quality of the sinonasal mucosa in determining the size of your biopsy, because you're going to expect impaired healing with an ongoing vasculitic process. But you should be able to get enough of the tissue sample to achieve a diagnosis if one can be gleaned. Often going to find chronic inflammation and possible vasculitic changes, but that might be the extent of your histology report. It's definitely something to consider. Despite its drawbacks, I have a fairly low threshold for it.
Okay. You mentioned that usually the histology shows chronic inflammation or something like that, but in an ideal exam world, what would the histological findings be for a biopsy to confirm GPA?
Again, there are certain findings you see. You might find microabscesses, hyperchromic giant cells, which basically just means the nuclei stain dark when you look at them under the microscope. You may see eosinophilic palisading granulomas. So these are areas of necrosis on the slide that's surrounded by palisades, or like rings of eosinophils and other inflammatory cells surrounding the necrosis. We talked about giant cells, so multinucleated giant cells in one or more systems, fusions of macrophages and monocytes, and then necrotizing vasculitis, small and medium-sized arteries and veins, so necrosis, vasculitis, and granulomatous inflammation. I think that last bit is probably your headline answer in an FRCS question. Everything else is just getting you further ahead.
And we've obviously been focusing on GPA, but there are some other granulomatous diseases that might present with ENT symptoms. We've touched on a couple already, but what are the main ones and how would you try and differentiate them from GPA?
So eosinophilic granulomatous polyangiitis, it's not a common condition. I probably see 3 or 4 cases a year coming through the clinic. They do have similarities, but also some differences. So we've talked about the anchor test. So the P anchor test positive rather than C anchor. So the difference being that in the P anchor, the antibodies bind to myeloperoxidase, or MPO, you've probably seen it as in the books, rather than the PR3, which is the myeloblastin or leukocyte proteinase 3 protein that you get in GPA. So you're going to get a slightly different anchor finding on your blood test. You're going to see eosinophilia on the bloods, which you may not see with your GPA. And they often have associated late onset asthma, late onset CRS with polyps and allergic rhinitis. So these, although they have nasal symptoms, you're going to be more likely to see nasal polyposis, but an intact nasal mucosa, or a less destroyed one, than you would see in GPA. They also sometimes have central nervous system involvement, such as neuropathy, and get cardiac complications, so heart failure, myocarditis, and pericarditis. So this patient who I was referred to earlier, he's actually got a raised trot. They're worried about recent ischemic heart disease, and they're suspecting eGPA. So they have a request for biopsy, which we'll do under local. So slightly different picture with those. Sarcoidosis, again, so a different blood test. So angiotensin converting enzyme could be elevated. It's not really specific, but it'll be raised in sarcoidosis. They get chest symptoms, don't they? So they might have pulmonary granulomas, primarily affecting the lungs, can affect other organs, but it's really classic hyaline-lymphadenopathy on the chest x-ray. They do have ENT presentations, nasal obstruction, crusting, bleeding, but they get salivary gland enlargement and laryngeal involvement as well, but you can get that in GPA. So slightly different picture.
So what do you mean by laryngeal involvement? Is that what to see?
With a GPA patients, you'll get subglottic granulomas and a subglottic stenosis.
Okay.
Whereas with sarcoidosis, it tends to be glottic or supraglottic.
Okay.
And then recreational induced. So these are the phenotypically most closely mimic GPA. When you look inside the nose, they'll have this chronically inflamed sinonasal mucosa that's granulomatous. They'll have thick crusting, possibly some dry blood. Mucociliary clearance is actually 0. They have stasis, nasal obstruction, absent laminar flow, paradoxical nasal obstruction, often huge septal perforation or destroyed nasal septum. They're miserable, these patients, really struggle with their symptoms. So they look the same phenotypically. Typically, they're systemically well compared to the GPA patients, and their pain is often a feature, less so with the GPA patients. They can get plated fistulas, so bad can their necrosis be. And then there's more recently recognised associated condition, which is levamisole-induced necrosis syndrome. Levamisole is a product that's used by some illicit drug suppliers to cut with the cocaine to make it go further. We published a case series here a couple of years ago of a series of these patients who come through with levamisole-induced necrosis syndrome. So very similar to GPA phenotypically, when you look at them, more likely to have pain, more likely to be systemically well.
I guess we didn't actually mention it in the examination section, but it's worth looking in the patient's mouth.
Yeah, it is.
Fistula.
Yeah.
Although I guess you would see that on your scope as well.
They do, yeah. It takes half a minute. And if you're not sure what's going on while you're gathering information, if you thought of something, you should definitely do it.
So this patient has got a diagnosis of GPA, and we've discussed their nasal symptoms and findings. How would you manage them if you were seeing them in the clinic?
Yeah, so key with these patients, as with all complex patients, is an MDT approach. You're going to involve rheumatology early, and generally as an opener with a lot of FRCS exam questions, remember to mention your MDT approach. So you're going to involve your rheumatology department. Very lucky here, we have them just across the hallway. From our side, we're going to help them with their symptoms, nasal symptoms, basic hygiene measures, saline douching, decrusting. They may be able to do it alone with saltwater irrigation done properly and regularly. I tend to show them a video online of how to perform it. We have free samples. I give them a sample and I'd ask them to persevere because it does take a few goes to get the hang of it. But once they do, it can be really helpful. If they can't clear the crust, they may need certainly initial help with decrusting under a short general anaesthetic to get them kick-started. You can take swabs, have a low threshold for antibiotics, or they may be colonised with Staph aureus, which can exacerbate disease flare-ups. So antibiotic choice guided by swabs that treating secondary infection can certainly help with their symptomatic control. Immunosuppression is the mainstay of treatment. So this is going to be managed by the rheumatologist. And depending on how sick you feel the patient is or how worried you are, will dictate the urgency of your referral. And that may extend as far as an acute admission to get them reviewed that day or the following day by rheumatology, because they will get better quite quickly once they're on the right immunosuppressive treatment. Obviously, any biopsies you're planning should ideally be done before you start the treatment to improve your chance of diagnostic yield. So steroids, immunosuppression medications like cyclophosphamide, azathioprine, methotrexate and rituximab are the mainstay of treatment, but they'll be managed jointly, and that side of things in our trust tends to be managed by the rheumatologist. Surgical management. So again, this depends on the size of septal perforation. Occasionally I've been referred patients with virtually no septum left in the collapsed saddle nose deformity for a consideration of a septal button. There isn't a button big enough and there's actually nothing left to anchor it on.
Yeah.
But, with a smaller, earlier perforation and some integrity of the nasal dorsum intact, it can be worth considering. And actually, most patients do remarkably well with them in terms of improving the airflow and managing the whistling that they can get with a septal perforation. You need some care of a septal button in terms of keeping it clean and regular douching, so you're going to need a compliant patient. If they have got laryngeal involvement, subglottic stenosis, I've got 2 patients within the department with subglottic stenosis who we have treated with balloon dilations for their laryngeal involvement of their GPA. And then another really classic FRCS question is considering reconstruction of a saddle nose deformity in a GPA patient who's been recently diagnosed. Loads to ask about. Can ask you all about the management of GPAs we've talked about today, and then extend into your reconstructive options and the timing of it and the technique for it. Suffice to say, it is an option. You want the disease to be well controlled and in remission under the care of the rheumatologist before you go down this route. You need to be realistic about the expectations. I think the advice I received when I was revising for the exam was 6 months, but actually in practice, but it's most people, and I think I'd include myself, I'd say 12 to 18 months disease control.
Before considering reconstruction. Yeah. Okay. Very interesting. All right. Well, thank you very much, Mr. Bowles. I feel like we've had a really comprehensive discussion about granulomatous diseases in ENT, especially GPA. We've talked about the presentation, differential diagnoses, assessment and management. of these conditions. It's been really great to hear from you. Thank you very much for your words of encouragement.
Okay, thanks very much, Dora.
So to summarise, granulomatous diseases such as GPA may present to ENT, and we have an important role within the MDT for the care of these patients. Today we've discussed a case of a patient presenting to clinic with sinonasal symptoms. The commonest cause of these symptoms is CRS, but we need to look out for red flags and be aware of the possibility of malignancy. The surgical sieve is a useful framework for considering your differential diagnosis. A full history and ENT examination, including FNE, will help you narrow down your differential. Be aware that granulomatous diseases may cause multiple ENT as well as systemic signs and symptoms. Useful investigations include bloods, CT imaging, MRI, chest imaging, and in some cases biopsy. Anti-PR3 C-anchor is 99% specific for GPA and 91% sensitive. Other granulomatous conditions that may present to ENT include eGPA, sarcoidosis, and cocaine-induced midline destructive lesion. In terms of treatment, MDT approach with rheumatology is paramount, and immunosuppression is the mainstay of treatment. ENT may be involved surgically in the management of septal perforation, subglottic stenosis, or nasal deformity, and reconstruction should only be considered if the disease is in remission for a significant time period.
Thank you, Dora and Mr Bowles, for this fantastic episode. Thank you to our listeners, and we hope you enjoyed this episode of the AOT Pod. Be sure to check out our other topics and give us a like and subscribe to get notified when new episodes become available. For more educational resources, visit the AOT website aotent.org and our YouTube channel AOT ENT Education, and make sure you come along to our amazing, inspirational annual conference where there are also prizes for presentations up for grabs. See you next time!